Now I want to explore what it's like to be a founder, maybe help our listeners think about what is it like to consider entrepreneurship as a physician.
Well, I have to tell you, when I went to college, I didn't have a computer in high school. And because of my math scores in high school, they recommended I take some computer science classes. And I didn't even know what they were talking about. I was like, what is that? Why would I do that? I'm going to be a doctor. That has nothing to do with practicing medicine. And, I kind of said, no, I'm not doing that stupid course. Like, that doesn't make sense. That has nothing to do with the career that I'm going to go save lives for a living. I'm not going to sit in front of a computer. So if my previous self could see me today, it would be very confused. Because I spend all my time behind a computer now. And I'm using a lot of tools and understanding technology. And I got my training in AI from MIT. And so just very different direction than I ever planned. I wanted to just take care of patients my whole life. But the credentialing identity theft situation essentially was just kind of the last straw. And so I never thought I would become a founder. I never thought I was going to start a company, but I've always been very entrepreneurial. In high school, I used to flip cars and things like that to make some money and, did some real estate investing and stuff over the years. So, I enjoy it because I'm solving a problem. It's a real problem. It's a real need. Everybody who sees the demos gets really excited, and it's way better than spreadsheets and Dropboxes.
Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and along with the fabulous team at the CMO Group, we bring you the most crucial conversations in healthcare and physician leadership. Today's show is specifically driven toward the power and result of physician leadership. We have a dynamic individual who's taking on one of the most challenging pieces of medical staff architecture and has the chops to do it. If you are a CMO in any hospital in the U.S., you will do yourself and your med staff a solid by listening very closely today. Our guest today is Dr. Leah Houston, founder and CEO of evercred, an agentic AI credentialing platform designed to modernize and automate physician credentialing. Dr. Houston earned her undergraduate degree in biochemistry and molecular biology at SUNY Plattsburgh and her medical degree from Albany Medical College. Upon graduation, Dr. Houston remained in Albany and completed a residency in emergency medicine, also at Albany Medical College. After more than a decade practicing emergency medicine across multiple states and systems, Dr. Houston saw firsthand how inefficient credentialing creates barriers to care and barriers to professional mobility. Her experience, including an event of credential misuse that highlights the systemic vulnerabilities, inspired her to build a decentralized agentic AI credentialing management system with solutions to streamline identity and the credential management across healthcare. She is a recognized thought leader on physician autonomy, decentralized identity, and the intersection of technology and healthcare delivery. Leah, welcome to the show.
Thanks so much for having me. I'm really excited.
Well, I'm very appreciative of having you on the show because I know, and we just spoke about it, your time is at an all-time premium. And so carving out a moment of your day to talk to us, I want to recognize that. And based on our prior conversation, I know that you have some critically important things to share, and we'll get to that in a second, but we have to set the table for the listeners. In a moment, I'm going to ask you to go back in time. Anyone who picked up on this during that intro heard me use the phrase credential misuse. And I don't think the rest of the show will matter at all unless we take everybody back in time, hit that from the start, and put that smack into the ears of the audience. So would you please share this personal experience that made you say something's got to change?
Yeah, of course. So when we get privileged at hospital systems, we kind of sign an agreement saying, hey, you guys have the right to use our credentials in order to bill for the services that we're rendering at your system. And really, that's it. It's just kind of like a blanket, here you go. And because the processes are so archaic at a hospital that I previously worked at, when I left, they continued to keep me on the roster as a supervising physician. And after I left the hospital, after I left the state, and actually my license in that state lapsed for a period of time, I learned that during that period, they were still billing under my name, committing essentially fraud against my medical professional credentials. And, that led the Center for Medicare and Medicaid at the federal level to be notified. It made it appear as if I was practicing without a license, when in fact it was really just a paperwork snafu at that hospital system, where they had me on this roster and somebody in the background was clicking and signing off on my charts. And I actually didn't know that that was their process. I thought I was the only one that was allowed to sign off on those charts, but apparently they had been doing that on my behalf the whole time, and I didn't know that. And so that's what led me to really dig into this. And as I started talking to other colleagues about what happened to me, I kept hearing stories, similar stories, people that worked for telemedicine companies that had durable medical equipment being ordered under their name. They had thousands of patients getting continuous monitoring under their name, and they never knew about it, nor did they even know who these patients were. So this is actually a pervasive problem. It's one of the things that's leading to, our healthcare system waste. And yeah, so that's part of why I want to fix it.
That's a major story, and the fact that others have experienced this is also disturbing. I wasn't aware of that. At some point, were you threatened with or put on the list of exclusions when it comes to future credentialing, or did you have to fight your way to get your name cleared and all of that?
So I did briefly lose my right to bill for Medicare and Medicaid, but as soon as they realized what was going on, they immediately reversed that.
That's important to recognize that, and for those who've never encountered what the government might do to you when it comes to your professional career, once they've set things in motion, it is very, very hard to go backwards. So I think while that was a horrible story, I think you got out pretty clean, all things considered.
Yeah.
So let's talk about how CMOs are beginning to process this story. What other pieces of that traditional archaic analog credentialing process are still broken relative to inefficiencies or lack of portability? What else can you describe that's still broken for many systems?
Well, every credentialing specialist I speak to, even people that are using the most advanced currently available software, the largest systems across the US, they talk about how difficult it is to actually get the doctor to do what they need to do or to update their things. And so there's really some systems have a portal where doctors can log in and upload things, but most systems, even large hospitals, they're still mailing them packets where they have to manually fill things out. Some of them are receiving things digitally over email, but it's still like a download and then re-upload situation. And if anything's missing or anything appears out of date, the credentialing specialist is really burdened with having to reach out to the doctor and getting them to respond. And these deadlines are tightening.
Hmm.
So, there's a lot of things. If you don't respond within 5 days, within 10 days, you have to start the process all over. And so that's a lot of administrative waste that happens from that.
And so as you outlined so nicely, this analog upload, download, it's like a new interface, but nothing's really changed. You're still doing it by paper. So what bubbled up into your mind as you began to think about evercred and how is it constructed compared to, just papers and signatures?
Well, so I went to medical school once. I went to residency once. It's a permanent credential. It's permanently verifiable, but we have to keep going back and verifying and verifying and verifying it because of the fact that there's no real standards around what verification means or what primary source verification means. So we created a space for doctors to actually store their credentials digitally and share them directly through the system, receive informations, notifications. Hey, you need to update this right through the application. We have text message notifications enabled. So that might help with the time thing as well. And then, if and when the physician leaves, they still have those credentials bundled in their wallet that they can take with them. That will make it easier for them to onboard to the next place. So this is kind of like permanently and perpetually verifiable record of my credentials that it's easily shareable and reusable.
So it's a very portable, physician managed, authenticated set of credentials. Is that a fair way to say it?
That's right.
Okay. And does and so from the way we're talking about it, the physician is the holder and the keeper of it. And like I think you hinted at using like an Apple wallet. I just show, here I am, here are my credentials, like my driver's license, anything that I use as an ID. Is that a similar analogy?
Yes. However, we do also have a portal that is hospital and practice facing.
Okay. So when I'm applying for privileges, I can connect the medical staff office or the CVO, the credentialing verification office, to that information and they can go retrieve it. Is that what I'm hearing?
It's a full credentialing suite.
Beautiful. And
Mhm.
tell me a little bit about you're seeing a lot of receptivity relative to it, or hospitals still unsure? Do the doctors prefer? Has it changed the dynamic at all? I guess is the generic question.
Well, here's the thing, I think that there's different kinds of ethos of every system. Our product is really designed for small to medium sized practices. It's not really designed for large health systems. Someday, a lot of CMOs have actually reached out to me over LinkedIn saying, "Hey, we want to try to use this." I don't know if we're ready for prime time at large health systems yet. But really, small to medium sized practices, they're still using spreadsheets, they're still using drop boxes,
Right,
and
right.
they are very excited about this, as are the doctors that work there.
Well, worked at several hospitals in a system, and as you begin to perfect that at a small to medium hospital, I can absolutely see the advantage within a big system. So I'm very optimistic for you to be able to do that as people reach out to you. What about some of those vulnerabilities that occurred to you early on? Does your process seem to limit those types of liabilities that somebody is in error continuing to bill under you?
Well, so once an organization actually uses the software, credentials the doctor, they have that data. That's theirs. Nothing's going to change there. However, when I leave the system, I can revoke my credentials.
And you do that on your end as the physician owner, or is it a two-way street? The other team has to acknowledge that you've left. How does that actually work in real life?
So in real life, so first of all, if I'm working at a hospital, I'm not going to revoke my credentials from them if I'm working for a place. So essentially, you have everything that you've ever done as an organization, but the connection between the doctor gets lost.
Got it. Got it. Okay. So a lot of systems are, especially the small to medium systems, they're sort of stuck with limited capital, limited margin opportunities, and yet everybody talks about digital transformation. How do you hope to begin to tell folks that this is worth the time and energy to get into the digital universe?
Yeah, so our first customers are really small to medium sized practices. So our numbers with them are different because, there's 12, there's 30, there's 20. But we did, kind of do some projections with one of the hospitals that we have an LOI with. They have 700 practitioners in their hospital. And they're currently, you know, spending over $250,000 on the software to manage the credentials only. And then they also have a staff that are around $2.5 million in staff that they pay to manage the credential. And that's really their whole job. And so we can bring the software costs down to like around $140,000. And then we always will need a human in the loop, at least now. Maybe 10 years from now, we won't need a human in the loop, but we can reduce the need for the credentialing staff down to like a 1 to 10 ratio of the currently existing staff. And then the actual agents can be deployed and you can deploy them in parallel. They can be deployed while you sleep. You can have dozens or hundreds or thousands deployed at the same time. And that could bring the cost of essentially the agents down to around 600,000. So we could save $2 million for systems like that. And if you think about it, it's not just the money savings of the credentialing process, you're also saving time. So if you do the calculations of time, if those doctors were able to get to work in a couple of weeks instead of 4 to 6 months, that's 63,000 hours of time, totaling, $560 million. And so these cycles only happen, every 10 years or so, but, $500 million is a lot of money, even over 10 years. So this is a real opportunity.
Yeah, with all the CFOs I've ever worked with, the last thing they want to hear about are what we call soft dollars. So you're going to lower the cost platform side, and you're going to increase the revenue by getting people on the staff billing on all the different opportunities. So that's a big win because not everybody can do both at the exact same time. So we look forward to hearing more numbers in the future as you build this out. Tell us a little bit more about what the AI is doing and how that's shaping your company and the technology.
So right now, there's this manual process. You have a credential. You need to do what's called primary source verification. Everybody knows about this. And what is that? It means you actually have to go to the external data sources and actually get proof that the credential's real. Now, how does that happen? It could happen in the form of just going to a website and typing in the doctor's number and their name and taking a quick screenshot and uploading that into your system. Um, it could be a phone call and a fax where you have to receive a fax and send a fax request for proof, for example, of education or employment history. So there's a lot of different workflows that are very manual that now can be done by AI agents. And what I mean when I say that is you can spin up an agent that can actually go to the website, click the buttons, fill out the form, take the screenshot, upload it for you. So you don't have to.
That is an incredible time saver for most docs. Nobody wants to go back and do that again and again. That's pretty cool. How did that idea surface, or is that just the confluence of the world that you live in with people that are thinking digitally? How did all that come to be?
Well, so I've always kind of known that at some point AI would reach maturity to do this, and now it has. We always knew that we could do data extraction. So we use OCR to extract the data from the credentials so you don't have to manually fill anything out. And so finally it's reached a maturity. So it's really exciting.
That's very cool. I mean, a lot of us are still AI naive, don't think about it. You're in a real great spot to be able to blend all of that. So we do have a lot of chief medical officers and associate chief medical officers that listen to this show, and maybe now they've been inspired a little bit to think about this and sit down with the staff and redesign something. So where might their first steps be about bringing in this type of approach from their vantage point? What recommendations or advice would you give them to begin to deconstruct and then reconstruct a better way of doing this?
We're happy to talk to large health systems and do design partnership for that kind of use case. We did sign an agreement with a 700-bed hospital, and we're hoping to launch with them in the fall. The product will be mature enough at that point for that. I'm happy to talk to anyone. I would love to, talk about how you're thinking about improving workflows. For an example, it's not just this path to revenue. You're saving money on time. You can have less need for credentialing specialists. You're saving money on the risk of incorrect data and information being put in there. Like a lot of people say, oh, AI makes mistakes and it hallucinates. Yeah, but when you look at how it does that in comparison to humans, especially in workflows like this that are very structured and you know exactly what's supposed to be done, there's a lot less errors already, and it's going to continue to get better and better.
Some of the delays that occur at an analog level is literally just trying to clean up what appears to be a red flag, but it isn't a red flag, and you're chasing it and chasing it and chasing it. And then, in fact, it was just a mistake on a piece of paper. And if it were more agentic in nature and cross-referenced itself, then it would likely close those error gaps. Does that make any sense how I describe that?
Yeah, yeah.
Yeah. So when you think ahead in the future and you have developed and matured this across different size hospitals and even larger systems, do you think there's an even larger evercred credentialing ecosystem? And what might you share on your future ideas about that for our listeners?
Well, you mentioned decentralized identity. Right now, physicians and their patients don't have access to their data. And so this could be used as a tool to layer in identity so that you could have better continuity of care. So we imagine a world where hospital systems and private practices alike will be able to find the right doctor for your specific needs. So, for example, you have a child who's blind. It would be really great to find pediatricians who have worked with a larger volume of blind children in the past, because those individuals will have more experience, more resources for you. So, just spray and pray and pick any random pediatrician on the insurance roster list isn't really going to work for people in the future when we have more access to this kind of information. Across the US, there's only like 3 or 4 doctors that are highly specialized in a rare disease called neurofibromatosis. They're only concentrated in large cities. If somebody has this affliction in kind of a more rural area, they have to travel an extensive period of time. Through a tool like this, we could do, telemedicine visits in the office with your primary care doctor with these highly specialized individuals, saving people time. So there's a lot of things that can be done with this. But first, we need to solve for credentialing, understand the competency, the skill set of the individual doctors, and create the robust infrastructure that allows for all these other downstream things.
That's a very cool idea of getting to the right person at the right time for the right reasons through some type of repository of closely held information, right? I imagine there's some security. You don't want a little system in the middle of the United States to take that credentialing information and then fraudulently bill. So I imagine there are layers that if I have a child with a rare disease, I can get to the doctor. But if I'm a crook in a building in the middle of Oklahoma, I can't get that information to do anything in a bad way. Am I accurate in suggesting that?
Well, this is more about telemedicine and collaborative medicine amongst practitioners too that can happen within their offices.
Right.
Yeah.
And as a practitioner, my credentials are still held very carefully by me and evercred and not accessible by the crooks out there.
Well, we're actually not sure. I think that there's a lot of processes within systems that have the opportunity for leaky, things like that to happen, whether it's intentional or not. And it's because we have these archaic systems in this modern world.
Yeah, that I agree with that 100%. There's still a lot of leaky things out there for sure. So tell us all a little bit about whether or not you miss practice and miss the emergency room and practicing emergency medicine.
Let me be very clear. If credentialing didn't exist as a problem, if all they had to do was check a quick background check, check my license, and just they know I graduated from medical school if I have a medical license, why do they have to reach out to my medical school? Doesn't really make sense, but that's how it is. If this onerous process of administrative credentialing wasn't a problem, I would be working. Founder journey has been, you know, let's just say it's a journey. And there have been moments where we've been really capital constrained, and being able to pick up a few shifts would have really helped. But the time and energy to credential led me to not want to do that. And I really do miss it. I loved taking care of patients. I loved working in the emergency department. It was a joy and a pleasure and a privilege to be able to care for patients, especially in those populations where a lot of people, this was the only care that they would get. It really was something that I really cherished and I valued a lot. And I miss it a lot.
Well, thank you for sharing that. Now I want to explore what it's like to be a founder. Maybe help our listeners think about what is it like to consider entrepreneurship as a physician. Talk to us a little bit about this journey.
Well, I have to tell you, when I went to college, I didn't have a computer in high school. And because of my math scores in high school, they recommended I take some computer science classes. And I didn't even know what they were talking about. I was like, what is that? Why would I do that? I'm going to be a doctor. That has nothing to do with practicing medicine. And, I kind of said, no, I'm not doing that stupid course. Like, that doesn't make sense. That has nothing to do with the career that I'm going to go save lives for a living. I'm not going to sit in front of a computer. So if my previous self could see me today, it would be very confused. Because I spend all my time behind a computer now. And I'm using a lot of tools and understanding technology. And I got my training in AI from MIT. And so just very different direction than I ever planned. I wanted to just take care of patients my whole life. But when this happened, and it wasn't just this, it was like the credentialing identity theft situation essentially was just kind of the last straw. I'd also experienced a lot of other things, just really inappropriate amounts of uncompensated administrative burden. Um, I'm sitting here one second comforting a mother because she had a baby that died from SIDS and brought them in. And the next minute I'm being yelled at by an administrator because I didn't, click this box or close that chart within whatever number of hours. It just was very discordant from what I expected. And so I never thought I would become a founder. I never thought I was going to start a company, but I've always been very entrepreneurial. In high school, I used to flip cars and things like that to make some money and, did some real estate investing and stuff over the years. So, I enjoy it because I'm solving a problem. It's a real problem. It's a real need. Everybody who sees the demos gets really excited. I believe our price point is at a point that small to medium sized practices can easily afford, and it's way better than spreadsheets and drop boxes.
Tell me a little bit about, as a founder, have you had to unlearn some of the things that were drilled into you, particularly as we become interns and residents, and a certain way of approaching, like you say, you go from SIDS to asthma, and then from asthma to chest pain was just an upset stomach. And all of those skills that you learned, did you have to unlearn a few of those to be a better founder? Has there been a transition and new things you've had to learn?
Well, I haven't unlearned anything, but I have applied different methods in different ways that I previously didn't apply. So, for example, I'm a scientist, background on molecular biochemistry, as we mentioned. Scientists want things to be perfect. We do a hypothesis, we test the hypothesis, then we find out the results, then we do follow up experiments. Physicians also want things to be perfect because if we make a mistake, somebody could die or be hurt. So, this tolerance for mistakes was very, 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 very low before I became a founder. But, move fast and break things is often, one of the sayings of a lot of tech entrepreneurs, where it's kind of like put your best thing out there, see what people say, and iterate on it. And so that's been a little bit uncomfortable for me because I really understand, I really respect the time of our customers and of physicians, and especially those who own private practices. And I don't want to waste their time showing them something that doesn't work. Part of the iterative process has been learning to sometimes put it out there, have a little bit of a higher tolerance for some, imperfections and get the feedback because that'll help make the product better.
Yeah, you just hit on something that I'm not sure we've ever had a guest suggest. So I'll reframe what I'm hearing. There is a desire to be as perfectionist as possible in delivering care to somebody because you don't want anybody hurt and you don't want a bad thing to happen. And as the founder slash spokesperson, you also want to present a tool or something to somebody that's highly effective with low risk. And, you don't want to hand them something where somebody gets hurt. But in between, as you're developing and designing, you might be internally breaking, failing fast, reiterating, iterate. So that's kind of holding two things at the same time. That's really unique, and I don't think I've ever heard anybody share that. So, anything you wanna add to that discussion?
No, I mean, I have to say, this has been very fun for me. I really, really enjoy the opportunity to be able to create a tool that's really reducing this friction point. People are like, why are you tackling that? It sounds too crazy. I'm like, that's why I'm tackling it because nobody else cares enough to tackle it. And I don't want to say nobody. There are a lot of people out there putting out new tools and, things like that. But, we're the first company to really be solving this from the physician's perspective at the same time as the perspective of the organizations and the institutions.
Yeah, I love that, vantage point. Well, I'll give you a chance to share anything that we didn't cover, last thoughts, things you wanna bring to the audience attention.
The agentic piece is really exciting. We're going to be launching our agents next month, and they're just the first agents for only a few different states. And we also have controlled substance database agents, and we're deploying APIs. So we're doing the API integrations and things like that. So I want to let everybody know, this is free to give it a try. Every physician can download the wallet, upload 10 credentials for free. They can get free notifications for expiring credentials via email, and even organizations can view one credentialing packet for free. And so this is kind of built to support independent primary care private practices who are kind of solo practitioners so that they can just get this done for themselves. But it's also to kind of do that iterative thing with any system who's kind of thinking, hey, are we ready to maybe transition to a new system? Let's check the system out. Let's see what it looks like. It gives you an opportunity to look at it. Most companies, they don't even let you see a demo without booking a call, but we're busy people. So go take a look, check it out, give us feedback. We are an early startup, so please be kind and understanding. And we look forward to serving you.
Excellent. And how should folks contact you and connect with you or obtain some of these products from you?
I'm on social media. I'm on LinkedIn. I'm on X. I do respond to messages there as best as I can. The best way to stay in touch with us as a company is to sign up on our website to put your information there so we can send you newsletters and things like that. And if you are a CMO of a hospital and you find me there, I will certainly reach out to you.
Well, I will vouch for Leah. I have connected with her on LinkedIn, and I was embarrassed because I started talking and then I drifted into a different universe, and then we reconnected. And she's great, and you guys can reach Leah that way. Among all the other things that she mentioned. And I'm very happy to hear about this as a former CMO. I think this is going to shake things up a little bit in a good way for so many people. And, you mentioned uncompensated time. I mean, we just want to get back to the bedside and take care of people, and filling out papers and that extra click, it is driving everyone nuts. So any way that you can make this better, we are very happy to see that happen. So thank you for being on the show. Thank you for sharing your personal story, your passion, your energy, for making things better for physicians and ultimately for patients.
Thank you so much for having me.
You have been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. You want to learn more about how to redesign your credentialing process? You just heard it here. Talk to Leah. Put your physicians in charge for once. It will work. How to really stand out amongst your competition as well when you're talking about credentialing safety and putting docs on your staff and putting them to work. Talk to Dr. Houston. You want to learn more about transforming your career and becoming a chief medical officer, then connect with me. Reach out to me on LinkedIn. I'll set you up with our CMO group and everything you need to lead in healthcare and how to credential your physicians. I love talking with CMOs from all over the world. So get out there, be a winner, be passionate, be a leader, be an entrepreneur, be a founder. Remember, whatever you do, in the words of Sergeant Phil Esterhaus, let's be careful out there.